Welcome, everyone. Today we have Dr. Noecker speaking now as our 12 o'clock. I am Vina. I'm the Glaucoma Marketing Manager, and we'll let Dr. Noecker take it away.
All right.
Thanks for coming.
Thank you, Vina. All right, and thank you all for taking the time to come here. So today I'll talk about a few things. I'll talk about my experience with MicroPulse, which is long-standing. I've been doing it for a very long time. We've gone through multiple iterations. I was originally, back when I was a medical student, I did research on continuous wave, original diode, transscleral psychophotocoagulation. So we've really seen the technology evolve over time in all pretty much positive ways. So without a doubt, with glaucoma, so I'm a tertiary glaucoma specialist, and almost all, 99% of my patients have glaucoma. So, the triple treatment algorithm for me, I do SLT first line because I think it's the best thing for the patients, and I tell them that. Then they do some kind of limited drug therapy, and then we start thinking about trips to the OR. And in the OR, the MIGS or microinvasive glaucoma procedures, we like them because of its risk benefit, especially for mild patients. It's safety, the efficacy is good, not great with MIGS, but it's the safety profile is really why we do it. Because otherwise, patients are earlier in the disease state, we want to be safer. As they progress, we're willing to take more chances and be more invasive. So as a general rule, most patients have had SLT, some medications in the office, go on to MIGS surgery, and then what to do after that. And that really becomes the breaking point in time, because we first started doing MIGS probably over a decade ago, and so these patients have done their thing. A lot of them are back on medical therapy, and the question is what the next step is. So we can do transconjunctival surgery like the Zen or trabeculectomy, or we can do a larger surgery like a tube, or I think this is where the sweet spot where MicroPulse fits in, because it has a lot of the attributes of MIGS, fast recovery, good safety profile, and very good efficacy without a lot of potential downtime. So when we think about why we did MIGS in the first place, it's good to think when that is, I don't like to say failing, but just kind of the disease is going through its natural progression. We have to take the next step in therapy. This is where MicroPulse fits in very well, because it has, I have patients who are farmers, who go back to work the next day after this procedure, which they can't do if I've done a trabeculectomy or a larger tube procedure. So it has a lot of good attributes, fast recovery, low risk of complications, and good efficacy once again. So we can get them back to what we had them originally after their MIGS surgery. And so once again, what we like about MIGS, this is putting in a hydrous device in this particular case. Small incision, relatively atraumatic thing to do. And most commonly, MIGS are done in combination with cataract surgery. There is a standalone MIGS market. It's relatively small though, and the thing is that cataract surgery by itself is helpful for glaucoma, especially early mild to moderate patients. That's been proven kind of without a doubt. Getting the lens out is a good thing. But when we combine it with the MIGS, we increase their chance of getting their eye pressures down to lower target pressures at minimal kind of extra cost to the patient in terms of work, in terms of inflammation, et cetera. So that's why we choose to do it at the time of surgery. That said, when the collector system is kind of getting worse with time, MIGS, work within that system. Angle-based surgery works within that system. So I always I speak in analogies to my patients. So I always said, listen, we're all like old houses here. And you got a 60-year-old house plumbing. And so we can, the medications are used to Drano. I say doing SLT is kind of running a snake down the drain, kind of cleaning up the drain a little bit. But sometimes you have to bypass the system. You have to go tackle the problem a different way. And so that's the point we're at. And so, and the native system in patients who are advancing tends to go away. You can reopen the canal all you want, or the TM all you want, but for some patients it's downstream, the whole system is just not working. That's kind of the way I put it to patients. So we have to choose more aggressive therapy. And so with MIGS, we have a lot of different options, but they really just have a lot of commonalities. These are inside the eye procedures. Once we start going out, These are kind of less invasive, a little bit more inflammation, a little bit more work than classic MIGS, where we're just working on the angle. But that said, they still have a lot of the characteristics in terms of fast recovery, good visual recovery, little downtime after the procedures. You know, the eye stent, this is a picture of a gonioscopy view of the eye stent, you know, back in 2011. So a lot of these patients have had surgery, you know, it's been a good decade since they had their first intervention. And just once again, knowing glaucoma is a progressive disease, it's not necessarily that the MIGS failed, it worked for a while, but what we see is usually after a few years, patients are back on medications, or we see that the IOP control is not as good as it may have been initially after the surgery. So this brings us to MicroPulse. And you know, what are some of the attributes? Once again, going back to traditional, you know, continuous wave therapy, you know, we kept it to the bitter end, right? What continuous wave therapy replaced was cryotherapy, right? So cryotherapy, you froze the eyeball. It was very painful for patients. Half of the patients got hypotony because it's kind of uncontrolled treatment of the ciliary bodies. And so when continuous wave came along, it was a big advance. The patients really didn't have a lot of they had a little bit of postoperative discomfort. They bounced back. Their hypotony rate really went down significantly. They had inflammation, but not nearly what they got with cryo. So when that came around, that was a big advance back 30 years ago. However, we know it has the downside. Some patients do, because you're causing coagulative necrosis, you do have some progression of effect, and we see this. Patients are controlled, and then they start going hypotenuse, and you really can't back it up. You can't bring it back in those situations, bring the eye pressure back up. So the advantage of MicroPulse is it's kind of the analogous situation I make is always with ALT versus SLT, right? Back when ALT came out, it was good. The studies showed it worked to lower eye pressure. It kept patients more stable than starting on the medical medications that were available at that time, but it came at a cost. It burned up viable trabecular meshwork. That was never the name. It scarred the canal of Schlemm, so you couldn't go back in there. And it limited in therapy, because there's only so much trabecular meshwork you can burn up and still get away with it. So SLT came about, which was basically accomplished all the same things, biologic upregulation without causing structural damage. And so MicroPulse is in a lot of ways analogous when we look at on the ciliary body. And this is what the burns you used to get. This is from some of our early cadaver eye studies. You know, these are the ciliary processes. This area where it's been cyclophotocoagulated won't make aqueous, but this will continue to grow, and basically there'll be chronic inflammation as a result of that burn. That's gone forever. There's no viable tissue. The anatomy's not quite the same. So it lowers intraocular pressure in the short term. The bad thing is the consequences in the long term. In contrast with MicroPulse, when we think about mechanisms of action, we're getting some of the attributes that we like to see with MIGS surgeries as well, right? We're not focused totally on the canal, but we're taking advantage of uveoscleral outflow. Much as prostaglandin analogs work, the drugs, they make the uveoscleral portion of this outflow system more porous, so we can lower eye pressure. A normal eye doesn't really need it, but a glaucoma eye where the trabecular system is not really working, the traditional outflow system, you do need that. And so if you can exploit that and increase uveoscleral outflow, as we do with MicroPulse, that's good. We're not kind of coagulating the whole region. We're increasing outflow at the same time we're decreasing aqueous production. So it's kind of the best of both worlds when you really think about it. You know, patients who've had MIGS surgery working on the outflow system, now we're going to do something that decreases inflow. So that's working on the opposite. So that's why we can have good additive efficacy, but also is working on the uveoscleral. So the other kind of two parts of the IOP control system is at play here. So if you like to think about mechanisms of action, this is from a purist standpoint, probably the best next step after doing MIGS surgery. So when you look, once again, going back to the clinical benefit, you see both methods, traditional transscleral in the short term, lower intraocular pressure very, very similarly, but it's the problems that you don't have. Prolonged hypotony from kind of overdoing it. And that's the lesson. Traditional therapy was over-treatment. And we've learned this a lot in medicine. Just the way we used to do PRP, ALT, we're chock full of historically, at first, we got a good effect, but we were way over-treating. We were treating more than was necessary. So I think we're starting to get it just right. When you look at the efficacy of MicroPulse, it delivers efficacy that you can get with a tube or a trab with arguably a lot less invasion of the eye, a lot less long-term consequences. So when MicroPulse first was first introduced a few years ago, it came out with a different probe tip. And part of it was a learning, we had to go through a learning curve clinically. A lot of times we found that efficacy was limited. It was sometimes, or you'd get it for a while and it would kind of wear off. You got some side effects such as a dilated pupil, which we learned comes from anterior kind of treatment. When you treat in the iris plane, that's much more likely to happen. And it was really unclear about optimal settings. We tended to use initially settings that were safe, but they weren't necessarily optimized for efficacy. So probe tip had some, I think, led to more side effects. Less efficacy came from probably not being aggressive enough into our settings. So we came about with this consensus panel of experts who are very experienced to kind of find best practices. These are people who have done hundreds and probably thousands of these procedures, came together to get some best practices. And one of the points of discussion that came out that is really, I think, important thinking from Thomas Grippo is that the idea of fluence, because typical glaucoma procedures, we basically do spots, right? This is something we can handle, right? See a spot, you get an effect, a bubble or a burn or whatever you might get. And you usually used to treat very finitely, whether it's PRP or whatever it may be. However, when you're doing a moving system, you have to change your concept, right? So fluence is energy delivered per given area, which is very easy to calculate if it's a spot. You know the spot size, you know how much energy you did, you do the math. When you're on the move, though, your dosing is different, right? So you're not delivering, your time component becomes the biggest variable in how much energy you're delivering in one spot because you're on the move, which being on the move makes it safe because you're not bombing it in a given area with a lot of energy. On the other hand, moving changes your dosing and it's easier to underdose. And that I think was a lot of our problem in the first, until it was pointed out that how fast you do this procedure is really what's the most important. So we had to kind of change our calculations, based on and introduce the concept of doing consistently the speed component or the sweep speed into settings. And that was really, I think, the biggest takeaway that came out of this is a lot of the early papers never even mentioned how fast you do it. And people, ophthalmologists or surgeons being people, and I'm one of them, I'm the least patient person like in the OR like ever. For better or worse, when you do the procedure, it's boring, right? The best procedure, nothing is happening. That's a good procedure, but humans being humans, it's boring, and you want to be done. So early papers really didn't discuss sweep speed very much, but when you went back and looked at the literature, we saw definitely a dose response curve to how much energy was being dosing, and the biggest variable was the speed at which the procedure was done. So from this panel, the recommended settings came about where a minimum, these are really, I think, consensus starting settings, 2.5 watts, 80 seconds per hemisphere, a couple times, 20-second sweeps, and then a 30, this is kind of a set duty cycle. So once again, I think these rose up from being lower preferred settings initially. So these are what we would say are starting settings unless there's some contraindication to use the usual amount. I personally do more. I'll discuss exactly what my settings are. I tend to be a little bit more aggressive. That's just my bias over time, and it just works better in my hand. But these are the starting settings. First crack around. And this is the standard treatment with the probe. So typically, I think one that comes out is that coupling is important. As you can see, there's some scatter of light energy, so we recommend using lidocaine gel, or I use lidocaine gel on the eye, or some other coupling agent. I like the lidocaine gel if there's any necessary anesthetic effect. It's something we have in the OR available to us all the time. And it helps, number one, decrease friction of the probe sweep so you don't get blood on the eye, which can block delivered transmission of energy, but it also helps couple the light because there is a gap, and if there's a gap, the light goes elsewhere. We'll come back to that. So here's the last part here, I'll present a couple patients who had prior MIGS surgery, which is, once again, more and more common just with time. More and more people have had MIGS surgery. African-American man, pressure is initially 30 and 29, moderate disease, so i.e. like a superior arcuate scotoma in both eyes, moderate cataracts, normal corneal thickness, on a couple meds. Pressures came down to the low 20s, but not like great IOP control. So, I think this is a very kind of typical scenario, like, what the heck, let's do MIGS. Let's do cataract surgery and MIGS. So at that time, my preferred, I did a combined surgery where I opened up the canal, I viscodilated, and then I left a trabecular bypass device in my hands that works, reasonably well. Came out the right eye, which did very well on no meds. The other eye's 26 on one med. We had that on latanoprost. 2 months, pressure was 20. Kind of borderline. His true target pressure is probably down in the mid-teens. And then we had to think, for the long term, that 20 is probably not good enough for this eye that's already damaged. We need to get it lower. So what else? We already did our kind of, I'd say, maximal MIGS. And then what are we going to do more? So in this case, the next step was to do MicroPulse. And these are the settings that I use, and these are, for me, my typical settings that I use on most patients. So I like to do this procedure in the operating room, just for safety of the patient, safety of me. So I do a block on every procedure because I find that when I do that, the patients are happy. Like, they get some propofol, they get a block, they had a happy day. So, and that makes it so if you do have to do and there is, some patients do need additional treatment, that they don't mind it. If they had some horrific, painful experience, they're often gun shy to come back. So for me, this works well. I find that making the eyelids lax helps avoid keeping that probe from migrating anteriorly. The new probe is much more ergonomic, so it's easy. I err on the side of leaving a little gap, a ½ millimeter or so of limbal tissue, just to make sure we're not, creeping anteriorly. So once again, we have to pay attention a little bit. And then the sweep speed is slow. It's 30-second sweeps, which I have to force myself to do. It's really slow to do 30-second sweeps, so it's not something that comes naturally to me. But I just watch it. The nice thing about the new device, it'll talk to me. I make my staff tell me every 10 seconds just so I can kind of keep track and stay engaged in the procedure. So do 90-second sweeps, and then do above, and then do below, and then I go above. So that's what this gentleman got in this case. I did lidocaine gel, the block, OR, he was happy. Next. So I typically don't see these patients post-op day one. That's the other advantage, I think, of MicroPulse, because we did for a long time, but it's nothing happens on that first post-operative visit. You're like, okay, you're doing fine, see ya. So on the whole, I see them typically about 10 to 14 days, sometimes in the second week, just because that's really decision time. Because number one, if they have inflammation at that point, usually most people don't, and then we can feel confident we can kind of finish off the steroids pretty quickly. Because once again, for those of us who did traditional continuous wave, patients often get chronic inflammation when you do, and so we have to kind of watch it, and sometimes don't take them off steroids very quickly at all. This procedure, we can get them off in a couple weeks, and I think that's important, and it helps aid them getting off quicker, making judgments about if their eye pressure got low enough after the procedure. So took them off over 2 weeks, pressure is 16 in both eyes on timolol, stabilized. So this has really been a win, and this guy's out probably about 2 years now. This is a win for. So once again, kind of minimal glaucoma surgery, which he needed, but also had a very good result. Other end of the spectrum, older lady with pseudoexfoliation in New England. I have about 20% of my patients have pseudoexfoliation. It's very, very common, just from the genetic makeup of Northern Europeans. She went back, she had original cataract surgery and eye stents back in 2013. So a long time ago, a decade. And she was damaged. So the right eye was worse than the left eye, and then her right eye just went bad. And we see this all the time in exfoliation. It's fine, it's fine, it's fine, and then it's not. And she was one of these, came in for every 6 months for almost a decade, and then showed up bad. So put on a maximal medication. She wasn't tolerating it. She was a little bit frail. It was a long, big trip for her to come in. How are we going to manage her post-op? So we decided to do MicroPulse on the right eye. She is actually someone with those treatments, so we did the same treatment profile. she actually had some numerical hypotony. She didn't have choroidals, but she had low pressures, which resulted in her vision being a little bit blurry for about a month or so. Came up, so we just treated with Durezol for a few weeks. Her pressures came to 12 in the treated eye, and she was happy and went about her way. She was a little cranky from her vision being decreased for a while, but here she is, and once again, same treatment profile, above and below, leaving a little bit of gap there with the newer probe. I need to try it again. So, for me, 1 week, 1 to 2 weeks is the follow-up period with this, which is a little different than our other procedures we do for glaucoma, certainly. Depending on the patient profile, I usually have them continue until I see them at that first visit. They've kind of gotten through, kind of the up and downs, and then we can start pulling off the medications at that visit. Steroids are really used sparingly in this procedure. Once again, probably a little bit of inflammation is a favorable thing. You just don't want it to be a lot. And most of the patients, we try to get them off relatively quickly. And then once again, we make decisions about 3 to 6 months. Some patients, in my practice, probably currently it's about a 10% retreatment rate, as we've gotten more aggressive and better at our kind of treatment settings. And then we can always retreat if they need an extra bump. And I find that once again, because of the relatively benign experience, most patients, no one likes going back, but they're accepting of it. It wasn't too traumatic. So, when we're thinking about, doing MicroPulse transcranial therapy, it has a lot of the attributes of MIGS. It's not exactly MIGS, but it has a lot of the attributes: fast recovery, favorable safety profile, has good efficacy, has complementary mechanisms of action, so we don't go back to the same well. We can move on and get some favorable effects. And it's certainly that we can titrate it and repeat it as well. So that's really where it fits in. So here's my email. If you have any questions, you can contact me. And that's it. Thanks for coming.
Thank you, Dr. Noecker. Yeah, does anyone have any questions?
I think they're stunned.
You answered everything.
That must be it. Well, thank you all once again. Nice to see you.
Thank you.
Thank you.